Welcome to the IA-PMD professional community. Our monthly cycle science webinars are led by experts in the field. This webinar will cover automating dimensional assessment of premenstrual disorders, introducing the CPASS R package. Please visit iapmd.org/CPASS for your copy of the CPASS package.
All right, welcome everyone. My name is Tory Eisenlohr-Moul. I'm the Clinical Advisory Board Chair at IA-PMD. This is the menstrual cycle science community. Really looking forward to our speaker today. Okay, great. So welcome, Laura. All right, you can go ahead and advance the slide. I'm just going to go through a few housekeeping things here before we get started with the talk. So we are super lucky to have Dr. Laura Symul here with us today. It's a postdoctoral fellow in statistics at Stanford, and she's going to talk about some of our work together, some of her work, expanding on some of my prior work to standardize the diagnosis and assessment of cyclical mood changes and premenstrual disorders specifically. So go ahead and advance the slide. All right, so this is the agenda for today. I'm going to start off by introducing the PMDD diagnosis. Again, most of you are already aware of it, but sort of the reasons that myself and Katja Schmellenberger and David Rubineau and some of the folks who were involved in this decided that we needed some kind of standardized system or standardized wording for talking about PMDD diagnosis. Motivations for the CPASS R package specifically, and then Laura is going to show it to us in action. She's going to give us some examples of how this would look in PMDD research, how to use it, so some technical demonstrations, and then how to format your data to actually get it into the package. All right, next slide. Okay, so I'm just going to talk briefly about PMDD. So premenstrual dysphoric disorders, the new DSM-5 2013 diagnosis in the Diagnostic and Statistical Manual of Mental Disorders. Symptoms need at least 5 of these 11 symptoms to be present in the week prior to menses, to improve with menses onset, and then to become minimal or absent in the week following menstrual bleeding. It needs to include at least one of the first 4 symptoms, which are the core emotional symptoms. So affective lability, irritability and anger, depressed mood or anxiety. The most commonly endorsed are affective lability or mood swings, and irritability and anger. So this is kind of stands a little bit in contrast to major depression, where sadness and anhedonia are the most marked. So 5 total symptoms need to show this pattern that I was saying, and then at least one of those has to be from the first 4. There needs to be distress or impairment. So my lab was just talking about this the other week. When PMDD became a diagnosis, there was concern about pathologizing all females. And so the test for that is really, we don't want to diagnose somebody with mental disorder simply because they're having mild cramps, right? That's not the goal here. The goal is to provide diagnosis and treatment for people who really have distress and impairment related to emotional or psychological symptoms in the premenstrual frame. The pattern does have to be confirmed across 2 cycles of daily ratings because the false positive rate is so high. We're going to talk about that in a little bit. It can't only be an exacerbation of another disorder, although it certainly can co-occur with other disorders. And there's plenty of examples in the literature of how you might separate symptom by symptom, which ones are sort of chronic and which ones are cycling. And then it can't be attributable to the effects of a medical condition. All right, next slide. In prospective representative studies, it looks like 5 to 6% of American females show a pattern that is roughly consistent with DSM-5 PMDD when we look at daily ratings. So it's certainly prevalent, but it's not all females at all. Next slide. And then determining who does have PMDD is a difficult task. So I alluded to this earlier with the fact that the DSM-5 diagnosis does require daily ratings in order to make the diagnosis. So structured interviews, unfortunately, don't match daily rating patterns. When we ask people, and I've seen this in all of my studies so far as well, unfortunately, when we ask people, the SCID-5 questions that really represent the DSM-5 questions, do you have these symptoms premenstrually? Do they improve? Do they become minimal or absent? People who say yes to those items do not reliably show cyclical changes in their mood when we follow them with daily ratings. And it's really unclear still why this is, whether this is some sort of, cultural belief system that is dysfunctional, or whether there's some sort of misattribution of symptoms to the menstrual cycle among some people. But it does cause this huge false positive problem. And it means that we have to use these daily ratings in order to, particularly in research settings, we need to use these daily ratings in order to identify people who really do have these changes that are observable right now, in order to study that phenomenon. So the most commonly used measure is called the Daily Record of Severity of Problems. And it really does simply sort of list, sort of a checklist of items, lists the DSM-5 symptoms of PMDD. All right, next slide. Excuse me. So these are all examples of data that I've seen from patients in research studies or in clinical practice. And, it's all well and good to say, just track your symptoms, right? And then we'll look at it. It turns out that it's actually a lot of data when you track all of the symptoms of DSM-5 PMDD across a couple of cycles, a lot of data. And it can be really, really difficult to know what to make of it. In clinical practice, generally speaking, people look for patterns. And I'd like to think that more often than not, you're able to sort of see the pattern in general and decide whether the person would benefit from some sort of cycle-related treatment. But in research, I think that's really not good enough. And it's probably not good enough for clinical practice either, although just getting people to do the daily ratings at all is sort of a win in my book. But for research purposes, we want a little more clarity than that, right? We want to know, we don't want people just sort of chin scratching and saying, do I think that they meet criteria? We want there to be kind of a structured way of making these decisions. And over the years, people have come up with a lot of different ways of making the decision about whether somebody's cyclical change in these daily ratings meets the DSM-5 criteria. So we'll talk about that next slide. Okay, so this is a table from the CPASS paper that I wrote with Katja Schmallenberger and David Rubineau and Susan Girdler and some other folks at UNC Chapel Hill. And as a first pass, one of the things that fascinated me as I was reading this literature is that people are doing wildly different things when they take these daily ratings and try to make a diagnosis or set sort of a threshold for, what PMDD is. And there were two major sources of variance. There's more than that, there's what days you select and all of that. But the things that really struck me as being the most variable were first the calculation method. So when you look at the premenstrual week, sort of the bad week, let's say, versus a good week, some follicular phase week, right? You subtract the two. That's typically done, in all of the methods. You sort of take the bad week and then you subtract the good week, right? So you say, how much worse are the symptoms in the bad week versus the good week, right? So that there's sort of always that basic subtraction done in the literature. But where the variability was the denominator. So when people talk about percent change across the cycle, I realized that they were calculating it at least 5 different ways that I could find. They were dividing it by the postmenstrual, the good week. Some people were dividing it by the bad week, the premenstrual baseline down there. So postmenstrual baseline, premenstrual baseline. The NIH studies, which have been so informative for our understanding the pathophysiology of PMDD, used the range of scale used or the full range of the scale as the denominator. Still other great studies use the person's standard deviation of that symptom. So really wildly different ways of calculating percent change, but then also differing thresholds. So 30% greater than or equal to 30%, 50%, 75%, one standard deviation. And what we found was that, different methods of calculating this percent, once you have the difference, resulted in wildly different, some it's much more easy to get a larger value than others, right? And then on top of that, people were sort of changing their threshold. And so what we did was, this was a sample of, I think it was 250, something like that. I should have had that on here, sorry. Patients seeking evaluation for PMDD. And so we did every combination of these to see in the squares here, what was the prevalence of PMDD when we calculated it all these different ways and set the thresholds in different places. And the differences could be anywhere from 3% of the sample diagnosed with PMDD all the way up to 54% of the sample diagnosed with PMDD, the same people. So I think it really goes to show that these small differences, what seem like small choices, can really lead to samples being characterized in totally different ways. And so what wasn't clear was, what is the one best way to do this? But what was clear was that we needed to pick something, or that we needed a way of talking about these researcher degrees of freedom, essentially, in making this diagnosis, so that we can have a shared way of at least talking about our decision-making here. Go ahead and advance the slide. So in 2016, I think it actually came out 2017, in January, we published this CPASS paper where basically we compared sort of a middle of the road definition. So we ended up using range of scale used and 30%, which produced estimates that we felt were sort of the most middle of the road and consistent with population estimates that we thought were reasonable. So we created this algorithm to diagnose, and we published it, and we compared it to David Rubino's visual diagnoses, which were it was sort of the best we could do in terms of a gold standard. And the agreement was about 98%. It was really very good. All right, next slide. So here's and so I invite you to read that paper if you want more details about exactly how we made all of the decisions and everything. But today is really about the R package. And so I want to get out of Laura's way a little bit here. But these are the dimensions that we work with. So it takes the symptoms from the DRSP and translates them into the diagnostic criteria. So it says you need to have this pattern that we'll talk about in, at least one of the core emotional symptoms and at least 5 of the total symptoms. All right, next slide. Again, we selected 30% relative to the range of scale used. That's not the only reasonable choice. That was just sort of a reasonable choice, but we called this relative premenstrual elevation. And the idea is that there needs to be a significant difference between the premenstrual week and the postmenstrual week. And even if someone chooses not to use the 30% cutoff, we wanted there to be sort of a way of referring to what the cutoff was, which is relative premenstrual elevation. And then absolute postmenstrual clearance simply refers to not having a value greater than 3, which is mild on the DRSP during the postmenstrual week. All right, next slide. And then, since we don't want to diagnose people with a mental disorder, if they are only reporting mild symptoms, the symptoms need to reach a 4, which is moderate, and stay there for at least 2 days in the premenstrual week. So if somebody's only ever having mild symptoms, we felt that shouldn't be diagnosed as a mental disorder. The duration needs to be at least 2 days, and yeah, all right, continue on. And then it has to be these symptom patterns have to be shown in 2 months. So for each symptom, it looks for 30% difference, at least 2 days of 4 or greater, symptoms not reaching a 4 in the postmenstrual week, and then we need at least 2 months of that. So that's how it does it. And then it basically calculates, does this woman meet criteria for PMDD? Do they have 5 or more symptoms in this cycle that show this pattern? They have 2 cycles that have 5 or more symptoms. Menstrually related mood disorder, we're not going to talk about that a lot here, but that's essentially saying, do they have at least one emotional symptom that shows this pattern? So it's a very low bar that's sort of intended to say, the PMDD cutoff of 5 might be too high. So is there at least one? Is there anything that follows this pattern? And then there's also dimensional symptom information that we can get from this. What is the average percent cyclicity in each symptom domain? How many symptoms meet criteria per cycle? What's the mean in the 2 weeks? How many days of severe symptoms, et cetera. So it gives us some sort of dimensional information that we can then carry forward into other analyses. All right, so I'm going to hand it over to Laura now to talk about the R package.
Thank you, Tory. Sorry, I couldn't find the unmute button, but thank you so much for the introduction to the CPASS. And I've seen in the chat that a few people have used the Excel sheet. And so one of the things that was also provided with the paper that you were mentioning before was both an Excel and a SAS macro. And so there are already tools that kind of can be used to automatically apply the CPASS algorithm. So why using an R package? And I'm sorry if it's a lot of text at once on the slide. We had animations, but with the technical difficulties, it's just exported in PDF. So there's all at once. But the main motivations for developing an R package that automatically applies the CPASS procedure to the RSP data that you may have for your studies are the 4 main following ones. So first of all, R and R packages are free and open source tools. So anyone in the community can contribute to improving the CPASS package. And yeah, it's free, open source. You can open the box, look at the code and see what's there and check that it does what it's supposed to do. And then R is one of the most common programming languages for statistical analyses in biology and medical research and psychological research. And so having an R package for the CPASS really allows to integrate the PMDD diagnosis procedure into standardized workflow for scientific research and for publications. And this is actually one thing that I think is very important, is that having an R package, and so not having to go back and forth between doing some, running some macro in Excel and then reporting the results back in another table, but just being able to run the whole workflow in R and to keep track of it within R script, is that it really supports the reproducibility of the research that we are all doing. And so having those scripts and those packages means that we can easily share with other people. And if we need collectively to change criteria or evaluate criteria or just be inspired by what other people have done, then this is very easily done. And so this is something that I think is quite important as well. And then finally, having an R package, and so basically a code, a function that just automatically can be deployed on any data that we have, is also something that comes at the right time, I feel, because so first of all, a lot of females, menstruating females, are using a lot of apps to log their symptoms. The PMDD questionnaires are available on the IAPMD website. And then a lot of the care has moved remotely. And so there is just like a lot of these data sitting that could be used for providing like remotely and quickly help to patients, like evidence-based, like screening tools on these data. And so hopefully this is also a direction that this can take. And what we had in mind, so the objectives of the R package as we are developing it, is to really provide a series of simple R functions. And when I mean simple, I just copied a little snippet of code here. So really that the whole workflow, it may be a little more than just 4 lines, but that the whole workflow can be really stripped down to the core. And so the core is to have functions that check the data. So look for any missing data, make sure that if there are too many missing days of reported symptoms, that there are some warnings, or like that the diagnosis is not run. Also maybe potentially look for outliers. So this is something, for example, the missing data thing is already implemented, but the outlier thing is not yet implemented. But it may be useful that if there is an obvious bad day in a series of good day, that this bad day is not necessarily removed, but that it's automatically pointed out to the attention of the researcher, of the CPASS package user. And so also to refer to the previous webinar when we talked about how to do cycle signs, there was a lot of there was a large diversity in terms of how menstrual cycle events can be coded and how they can be detected, either from bleeding patterns or from LH tests and so on. And so we wanted to include, or at least be flexible on these different types of how participants to study input their data and how the cycles can be coded. And again, with the hope to standardize this and harmonize this between studies. And finally, obviously, apply the CPASS procedure to provide diagnosis for PMDD, MRMD, and also PME, and this still has to be clinically validated. And here PME stands for premenstrual exacerbation of symptoms. And that is just acknowledging that someone may have a higher baseline in symptoms and still have higher, a higher severity of symptoms during the premenstrual phase. And finally, and I really love data visualization. And I think it also is important to have tools that provide publication-ready visualizations. And so this is just here you can see in the very small on the side, but one of the visualization where on the top we can see some of the summary output of the CPASS. So we can see for each item how much was the percent change that Tory just explained, and then also have a quick glance of the raw data and see which items met criteria for PMDD or for PME, and at the cycle level, which cycles met criteria for these diagnoses. And so with this, to just demo this package and try to show how it can be used for research, and maybe also for potentially for basic research, because it outputs more than just where there is a diagnosis of PMDD, but it also shows how the average percent change for each symptom is different or is evolving through time or between participants. We designed a little fake study that goes like this. So let's imagine that we have a clinical study for new treatment for PMDD. And so how the study is designed is that there is first a recruitment phase before the actual study phase, where patients who complain about symptoms or in their luteal phase are recruited. And then there is a pre-enrollment phase where these participants, would be asked to report their daily rating of severity of problem for 2 cycles, because as Tory explained, there is not always a match between what people remember about the symptoms patterns and their actual symptoms pattern are. And then only the participants who meet criteria for PMDD would be included in the study. And then 50% of them would be randomly given a treatment and the rest would be given a placebo. And after 3 cycles of treatment, participants are asked to report their symptoms again for 2 cycles. And then the analysis would be to evaluate the benefits of this new treatment compared to the placebo. So this is just a fictive case study. We simulated the data, so they're all fake. They're not actual patient. There is not an actual treatment that was tested here, but it's just to demo the package and show a little bit how this can be integrated into our workflow for the analysis, the statistical analysis of this study. And so if I just look at the pre-enrollment data, so this is here a big table. I'm sorry, it's a little small, but basically you see that maybe about 244 subjects here. So it goes from subject number 1, subject number 2, and ends with subject number 244 have been enrolled for the screening, and they have all reported data for 2 cycles. So we see cycle number 1, cycle number 2, and then for 2 phases of the cycle, the premenstrual phase and the postmenstrual phase. And so that goes from days -7 to -1, and then from day 4 to day 10. And then they reported the severity of problem on a scale from 1 to 6 for all 24 items. And you can see there are some missing values because maybe some days they forgot to track their symptoms. Again, these are fake data. I just try to mimic actual behavior. And so if we now apply the CPASS data to this, the CPASS package to this data, so we first read the CSV file, and then we do a little bit of formatting to make sure that instead of having one line per day, we actually have one line per subject, cycle, day, and item. So it's in a long format. And then we have this function here that's as CPASS data that basically is going to check that the data is as it should be formatted, that has data for most of the items. It's going to tell you for how many subjects and how many cycles you have data. And it's also going to check the amount of missing data and let you know if there are too many missing days. And then finally, we can apply the CPASS procedure just by calling CPASS on the data that we just formatted here. And then we can have a table of how many of the subjects didn't meet any criteria for any diagnosis, how many had mood-related menstrual disorder, how many had PMDD, and how many had premenstrual exacerbation of the symptoms. And so here we see that in our 244, I think, subjects, 67 of them actually meet criteria. And if we want to look a little deeper into the changes in their and the severity of problem, for example, for the first item within the 24 items. So I think this is feeling depressed. We see that, so here we have the percentage, and then the participants have been split into their diagnosis. And as you can see, first of all, at the bottom, there are some participants that do not meet any criteria for any diagnosis because they didn't have enough data. So these will not have no diagnosis, they will just be missing diagnosis. And that's because there were too many missing data. And what we see is that patients with PMDD, most of them had between 25 and 75% increase in their symptoms in the premenstrual phase. But a few of them had actually no increase or even a mild decrease. And that means that probably feeling depressed was not one of their symptoms that met criteria for PMDD, but they probably had other symptoms for which they met criteria. And similarly, for those who didn't meet any criteria, we see that there is a maybe longer tail and that some people actually do feel less depressed in their luteal phase. And so these are, again, simulated data, but roughly correspond to what you may actually see in data. And so if we continue and want to look a little bit at the raw data, like you may want to have a look at the data from each of the participants. And so here, this is like this big bird eye view on the data of two different participants. So one participant here met criteria for PMDD, and this one didn't. And you can see that here on the top, we have summarizing visualizations, and I'll come back on those a bit bigger on the next slide. And then at the bottom, we have the raw data. And so immediately we see that, okay, the person with PMDD, first of all, had a higher baseline, like we see higher symptoms, higher severity of symptoms than this person. And then also that in the premenstrual phase, their symptoms were higher for a few items, and in total, enough items that they met criteria for PMDD. While this person didn't, they just had like one day bad headache in the postmenstrual phase, and then were very angry one day. So that's not enough. And so if I just zoom in terms of what we get as a summary, so we see the subject identifier, we see the final. So this is yet another subject that met criteria for MRMD. And so we see how many cycles we had data for them in total. So here there was 2, and how many cycles were included. So it could be that, you know, some participants filled data for 3 cycles, but there wasn't enough data for 1 cycle. So this will tell you, okay, 1 cycle was missing. And then tells you how many cycles met criteria for PMDD or for MRMD. And then it will show you the daily averages in the postmenstrual phase and in the premenstrual phase, and as well as the average percent change between the pre and the post phase for each of the symptoms. And the color here is just to differentiate between the different items within a DSM-5 symptom. So here, they didn't feel more depressed, but they felt more hopeless, hopeless and worthless, for example. And if we look at the actual data on the next slide, so this is for the first cycle, we see again like the baseline is around 2 in their post-menstrual phase, but then it goes higher in the premenstrual phase for a few of these symptoms. And we can see here which items light up, so meet criteria. And then if one of the item meets criteria, then the domain or the symptom meets criteria at the DSM-5 level. And then at the cycle level, we can also see what are the criteria that are fulfilled. So if we now move to the next phase of our little fake study and look how many patients, so we had about 70 something patients that met criteria for PMDD at the pre-enrollment phase. And so we'll just randomly split them between the placebo group and the treatment group. And again, we'll simulate data and then we'll load this simulated data. And I simulated the data such as to give us some hope that the treatment and the placebo, so first of all, both of them had an effect at reducing the percentage of PMDD because we started from 50%, but then in the treatment arms, there were less people who met criteria for PMDD after the treatment. And so that's results we all hope for. And then from this, we can continue the analysis and do a bunch of other statistical tests or just data visualization. And for example, another question that could be a follow-up would be to use these average person changes that are reported by the CPASS and maybe check if there is one symptom in particular that is especially reduced in severity with the treatment, for example. And so there are from there a lot of analysis that can still be done with an R with these data. So if I went a little fast on this, or if you'd like to actually see the whole code and play yourself with the data and simulate some data yourself, this is all available online at this address. And I think the slides will be shared, but you can just quickly take a screenshot otherwise. And this is also something that I think or hope can be useful to have data to have functions to simulate data, because it can be really good to make some power analysis to be able to see, okay, how many persons do I need if I anticipate that my effect is going to be that much, for example. So I hope this is going to be useful. And then actually on this website, trying to advance the slide here. So there is a website for the CPASS package. So it's here on my GitHub repository. So just lazy github.io and then /CPASS. And on this website, you'll find all the technical details that you need to be able to install R if you don't have R yet, to install RStudio if you don't have it yet, and to install the R CPASS package if you don't have it yet. And there are also a lot of instructions and demonstrations and a lot of documentation that's available there. If you still have questions, really feel free to contact me anytime and let me know what you need or what doesn't work. And just here to complement what I said, and again, this is on the website, so you'll find everything, but the steps to use R is just to first install R, which is the language itself. And then RStudio is just a programming environment that makes it a lot easier to use R. And then the CPASS package, as I said, the instructions are here, and I see someone copied the link in the chat, so that's great. So there is also, again, really an introduction to the CPASS package page on that website that will really guide you through the steps. And that has demonstration that shows you all the options that you can find in the package. And then finally, if you want to use it and you have at home or in your lab some data that you'd like to test this package on, so the best way to get started is to have your data in a CSV file. And so if you are used to Excel, it's very easy to, from Excel, save as CSV. And as I explained earlier, there are some functions that are embedded in the CPASS package that can help you code your data. So if all you have is a date and bleeding patterns, for example, the as CPASS function is going to just detect automatically the cycle starts and start counting the day forward and backward and identify the cycle phases. In the future, these functions, the cycle coding functions, will likely move to another package so that we have, on the one hand, a function that can help you code your data, and then on the other hand, a function for the CPASS package, so that all the functions that are related to coding data, and that can be, just data from a few persons to data from thousands of participants if you have those data, so that they can be used for any menstrual cycle research and not necessarily just PMDD related studies. I'm sorry. All right. And
Laura, I just wanted to, sorry to
yes.
interrupt. Hannah just asked a question that I think is, you basically just answered, but I just want to draw your attention to it. She's saying, I can imagine parts of the package would be useful for PME or prepping cycle data sets for other scales. Is that possible? Or does it need to be in the CPASS format? And she says it's amazing, which is really nice. I know that for PME, Laura has implemented basically a PME version, which all it does is it eliminates the requirement of clearance. So there's a dimension in the CPASS called absolute clearance of symptoms. And that's basically exactly what it sounds like, so it basically just eliminates the requirement that symptoms go away completely. So that requirement where I was saying it can't be greater than mild, it can't be moderate or greater, basically just takes that away from the follicular or post-menstrual requirement. Do you want to speak to the prepping data sets for other scales? I think it's
Yeah, absolutely. So right now, within the CPASS package, there are those data coding functions. And again, you may need to do a little bit of formatting once you load your Excel file or your CSV file into R. But right now, if you have, as I said, like bleeding or just cycle start, like this will automatically code your data. And we're working on, I think it kind of makes sense to separate the two. So having a cycle code package that's really, what it's going to do is basically translate this paper that Katja presented last week on how to use, like how to study the menstrual cycle. And, we saw last time that there were so many ways to identify ovulation or to decide on a cycle start. And so basically this package could be doing this. And then the CPASS could be used for PMDD, PME, MRMD. But then if you don't need diagnosis, but all you need is person change, or if you want to do any other kind of analysis, then at least the cycle coding is, again, standardized and can be shared among scientists. I hope that answers. If not, feel free to ask again or ask clarifications later. So thank you. And so just to summarize and look a little bit into the future. So what has been said so far, I think like Tory made it very clear that diagnosing PMDD is not a straightforward case, just because indeed there are lots of symptoms, there are a lot of data. And so it was kind of necessary to come with a common language and an algorithm to standardize that task. And so the CPASS R package is really an implementation of this algorithm. It will give you the same result as the Excel sheet or this SAS macro, but it's free, it's open source, and it's collaborative. And it's really the language that has been used for statistical analysis and more field, especially the biology, psychology, and medicine field. And as I said, it's also still work in progress. So as you guys will use it, feel free to, again, contact and, sorry, contact us, give us feedback. It's really meant to be a tool built for and by the community. So very welcome. And in the future development, we're thinking about different visualization options and then making the PME optional or like included in the visualization, having this coding separate from the CPASS algorithm. But then if there is anything else that you would need and would be used for your research, I think it's really kind of a base for having, for developing the cycle science together on R. And I think I'm done with the presentation of the CPASS package.
And we will see you next time.